Good afternoon, everyone. I hope you can all see the screen. And thank you for this opportunity. It's a great privilege to talk about some of the work of Kisiizi Hospital. And I hope you can all see as we go through, talking about the move from theory to real-world practice in Uganda as we look at the multifaceted approach. I'm going to give you a bit of introduction, and I'm going to tell you about some of our World Health Organization programs to do with patient safety, and then give you some examples of implementation of theory in frontline practice. I hope you will find it interesting. Those who have never been there, Kisiizi is in the southwest of Uganda in Rukunjiri district, and it was established in 1958. It has 285 beds, a remote, hard-to-reach rural situation, 32 kilometers from a tarmac road. And some of you will know we have a very beautiful waterfall. We serve a very poor community, mostly subsistence farmers. We have a school of nursing and midwifery with around 200 students. We have around 55,000 patients coming through our general clinic and about 2,200 antenatal new patients every year. We admit over 9,000 patients with over 58,000 patient days. We deliver 2,245 babies every year, and we have a 28% section rate, partly because some of the patients are coming in with problems from the community. We do over 3,000 operations a year and transfuse over 500 patients. So that's just to give you some background. And we have a whole range of specialties. This is our neonatal unit when we were doing a couple of exchange transfusions on babies with very severe jaundice who were at risk of brain damage or deafness. And it all relies on very key staff who we're very grateful for. So a little bit about the World Health Organization links. Kisiizi, one of only 3 English-speaking countries in the first wave of the African Partnerships for Patient Safety. And we're linked to the Countess of Chester Hospital in England. Now this program covered quite a wide area. It included infection control with a focus on hand hygiene and the production of alcohol-based hand rub, the appointment of an infection control nurse, and the use of triage, surveillance and audit. It also looked at various aspects of waste management, including disinfection and safe prescribing in a number of ways we'll talk about, and the whole emphasis too on safe surgery. It then, as the program developed, we moved to having a full-time patient safety nurse, and we amplified the training in local district hospitals and institutions and received a team from Zambia that the WHO sent for training in Kisiizi. And because the program worked well, we also moved on to a surgical research program. Other areas that we covered included patient safety aspects of mental health, improvement of imaging resources, the provision of a biomedical workshop, and networking with the Ugandan Maternal and Newborn Hub, with emergency obstetrics training with colleagues from the Royal Berkshire Hospital. Now this was very practical. These are real-world frontline things. So for example, the provision of individual towels for drying hands instead of one towel for a department. The provision of segregation of waste and proper laundry management. And everybody was involved, and the training tried to mobilize everybody we could in dealing with infection and reducing risk. Now here we see a group in training where they are seeing how hand rub is prepared, alcohol-based hand rub to the WHO recipe. We've introduced and assessed the use of safe surgery checklists from WHO. And here are the team from Ndola Hospital in Zambia who came for training in Kisiizi. One of the things that we did in the training were role plays, and here you can see a team demonstrating the surgical checklist in action. We published some of this in the Royal College of Pediatrics magazines, and a paper that we produced as we did further training in our district won first prize in 2013 in Geneva at the International Consortium for Prevention and Infection Control. So we were very happy. We beat China, we beat Germany, and that put Uganda on the map. Now, at the end of the program, we moved from the part-time infection control nurse becoming a full-time patient safety nurse, and having that emphasis on safety as the main reason for the role was really valuable, rather than having somebody doing it in their spare time. And we also have patient safety champions in each of our departments. Because the program went so well, we then moved on to the surgical unit-based safety program, which was run by WHO together with Johns Hopkins University in the States. 5 hospitals in Africa were in the program, 2 in Uganda, the other one being Malago National Referral Hospital. And Kisiizi was featured in the WHO website last year with this work. And the interventions involved demonstrated a reduction of complications from 8% down to 3.9%, and this was sustained. We were also invited to be part of something called the Universal Health Coverage Patient Safety and Quality Learning Laboratory in Geneva, along with institutions from other parts of the world, to look at how one can deliver patient safety on the ground. So what we want to particularly focus on in this webinar is implementation, because there's a great deal of theory and a lot of evidence-based knowledge, but the challenge is, how do you translate that into something that's real world in a resource-poor setting, that is frontline, that is consistent everyday practice. Now, the WHO focus a lot correctly on universal health coverage, and this is one of their graphics showing that it has a range of different aspects. And the question is, how do we translate these into everyday practice? And I hope I'm going to show you some of the ways we found useful. In March this year in Thailand, there was a WHO seminar where they talked about the contribution of integrated people-centered health services to ensure universal health coverage. And they related that to the right to health and leaving no one behind in the Sustainable Development Goal era. And they emphasized that there's a need to ensure that the voices of the most vulnerable of populations are included on the path to universal health coverage. So the question is, how can we do that? Just a few days ago, the new Director General of WHO, Dr. Tedros, was emphasizing the importance of the SDGs, and he summarized in 3 points: keeping the world safe, improving health, and serving the vulnerable. And you will see that's some of the things we've focused on. So we've got the challenge of going from theory to frontline practice. And if we take the example of care for the vulnerable, for example with malnutrition, what can we do? And we've developed a nutrition unit on the pediatric ward with a demonstration garden to teach families how to produce crops. We have a chicken project to show how to rear chickens. We have a goat project and the Good Samaritan Fund to support the very poor. So when we see real people like this presenting to us, this is a little child with very nasty edematous malnutrition, we get them better with the standard approach pediatrically. But you can see this child, although he's much better clinically, he's still wearing the same shirt. And that, of course, is because that's his only shirt, and that's a reflection of poverty. So we have developed the production of ready-to-use therapeutic feed to a WHO recipe. This was partly a frustration that we could not acquire the commercial version for some reasons available to our district in Uganda. The GOAT project provides backup, so for the really poor families who even after education cannot implement some of these changes, giving them a pregnant goat helps them for the future and can transform their possibility of looking after their children. We also run child sponsorship programs that again can then support some of these vulnerable children that come in through the hospital. Now, recently also, there was a WHO session in China where the Director General spoke about universal health coverage as the key to the health system. And he talked about China leading by example with over 95% having basic health insurance. So we want to talk about how that translates into Uganda and how we include the vulnerable and integrate a people-centered approach. And one of the ways is the health insurance scheme. Now this is quite an exciting story. This was the first community health insurance scheme in Uganda, starting in 1996. And the strapline is affordable access to quality health care. We charge an annual premium that's only 10,000 to 14,000 Uganda shillings. That's around £2.15 to £3.10 in sterling. We now have over 38,400 beneficiaries in 204 community groups in 4 different districts up to 60 kilometres from Kisiizi. And the programme has run without any external donor support. And these 204 groups will meet together, they will have health promotion, and they are very keen for this programme to work because they know that they could never access quality health services at that price anywhere else. This is a picture from the annual general meeting last November, and each of the people in the photographs are group leaders, and they will each have maybe 50, 100 or 200 members in their groups. The senior doctor in Uganda, Dr. Joel Okulo, the chair of the Uganda Medical and Dental Practitioners Council, said this about the scheme. What amazes me is its simplicity, effectiveness, enthusiasm, and that it addresses the needs of the people, building on existing structures run and owned by the beneficiaries with no outside funding. And here you can see some of the recent years of trend of the number in the scheme, and we're now at the highest level ever, and we anticipate this going up further as we've recruited a new manager in the last few months, and I think we're going to see it expand quite a lot more. So the key principles behind the scheme are the community must trust the provider that the services will be available, it needs to be not-for-profit, and community must be involved. And we think that if those 3 principles are followed, this scheme is replicable in other parts of the country and beyond. Another aspect to universal health coverage is time of day, that the services need to be available not only geographically but also in time, so that you should get the same good care at 2 AM as you get at 2 PM. I mean, that's a challenge for the NHS as well as Uganda. And how do we implement that in practice? Here is a photographs from 2 different operating theatres taken at the same time, 11 o'clock at night, through the windows of the theatres when 2 major operations were being conducted in Kisiizi at the same time for life-saving problems. And that's quite a challenge to produce that level of cover that the services are available. So I'm trying to show you some implementation of theory. If we look at accessible quality of healthcare, we've had a couple of initiatives that we think have really made a difference. First of all, the Mother's Waiting Home. Now this project came out of a tragedy. We had received, I think in 2011, 2 mothers arrived in Kisiizi already dead because they just could not get to us in time, and they had complications of labour, and by the time they arrived it was too late. And the response was we built this new unit with 26 beds, and people can come and wait in a place of safety. We provide health education and promotion to the mothers who are staying. They pay only 5,000 shilling as a one-off fee, that's about £1 in sterling, and if they're in the insurance scheme it's free. We give them hot showers, they're reviewed by a midwife every day and by the obstetric team weekly. And that has proved so popular, and it has really taken down one of the barriers because people can travel electively instead of having to come on emergency transport, and that's much cheaper and much more convenient. Another whole area for patient safety is mental health, and we are still getting patients coming shackled in distress. We've had a wonderful partnership, partly with the Cheshire and Wirral Mental Health Trust. This picture shows Dr. Maureen Wilkinson, a consultant psychiatrist, with Sister Nancy, who's a psychiatric clinical officer in Kisiizi and heads up the programme. We've been able to establish outreach mental health clinics. Every month we're seeing 80 to 120 patients per clinic. So there's a huge demand because no one else is going out into the community taking this service. We've also established mental health community patient groups, and these have helped to reduce stigma and have helped to encourage the patients and support each other. Now, we're very proud of this. This is the most recent building in Kisiizi and has just been opened. It's the Ahamuza Centre. Ahamuza means place of comfort. And this is the first purpose-built mental health centre in a rural area anywhere in Uganda. This is the Permanent Secretary of the Ministry of Health arriving to open the centre, Dr. Diana Atwine, and she was a wonderful guest of honour. And during the presentations, we had a drama by our staff and students illustrating the challenges faced by some of our mentally ill patients and the way they can be helped to come back to a really positive life. We're hoping to expand our mental health community services and also to introduce epilepsy services. And we want to use the World Health Organization MHGAP guide and training tool to facilitate that. Another area of patient safety is reliable equipment and safe equipment. So we have set up a biomedical workshop, and this helps to maintain and look after the equipment. We have some sophisticated equipment like this ultrasound scanner. We have other more simple mechanical equipment like this gentleman in the rehabilitation unit is using, but it all needs to be maintained to run safely. So we have technicians, and we were able to actually run the first ever regional biomedical training conference in Kisiizi, which was great. So caring for the vulnerable needs lots of things. It needs good equipment, it needs trained staff, and the support of things like the laboratory. This is our lab in Kisiizi. We now have things like Gene Expert for identifying tuberculosis and also recognizing resistant organisms. Behind all of that, we have our hydroelectricity turbine. This is 300 kilowatts, and we send electricity 7 kilometers from the hospital as part of our services. We also filter water for drinking in the wards and in outpatients. Now, all of this translates into care for patients, and here's an example of a mother who had triplets simultaneously, born 2 months early, in the night, all of them with breathing problems. And this is the going home. So it represents the fruit of a lot of the things I've been talking about. And here they are growing up a year or two later, and you can see that was a really good outcome. Now, providing quality health education and promotion, we found that local language videos are a useful tool. And here we can see part of our outpatient queue looking at a health promotion video made in Ruchiga, the local language. We hope that this will reduce the avoidable diseases which we sometimes see. We also use videos in things like the diabetic clinic for training patients specifically about lifestyle aspects of their management, and we found that really helpful. We're also, by the way, doing HbA1c testing, which seems to be uncommon in Uganda, and yet we would argue is one of the most important investigations in managing diabetics, which is becoming, of course, a bigger and bigger problem as non-communicable diseases increase. So we're trying to impact real patients in the real world with these interventions. This is the document that was produced in 2014, published by WHO as a result of the discussions we had in Geneva. And the question is, how do we implement the principles that were established in work like that? How do we integrate patient safety and efficiency? And one of the ways we've developed is an IT program called Streamline, and I'm going to tell you a little bit about how that works. Streamline is aiming to integrate patient safety and efficient health service delivery using IT. We had a grant from the Uganda National Council for Science and Technology, for which we're very grateful, to help us do the initial development. When you open Streamline, you find all the previous admissions and encounters with a particular patient, so you can see straight away the history of that patient. We now have over 60,000 patients on Streamline in Kisiizi and in our second pilot site, which is at Rugarama Hospital in Kabale. Now, one of the things we've incorporated in Streamline is the use of prompts. So rather than waiting for somebody to ask a question, we prompt. And we prompt whenever you put in a symptom or a diagnosis, an investigation or a treatment. And that means that these prompts are available 24 hours a day. And particularly when we have new staff, it really can help them to follow the correct procedures. So here's an example. This is ibuprofen being dispensed, and this is a prompt that has appeared. And for example, it's warning the prescriber, don't forget that this drug is contraindicated in severe heart failure. Another thing we've introduced with Streamline is its use in pediatric triage. Here is a patient undergoing triage with one of the nurses asking questions. Now, first of all, they will ask about symptoms and put in the vital signs. Now, Streamline knows the age of the patient, and it therefore puts the correct normal range data for that age group. So you will know that respiratory rate, for example, is different in a child of 2 months, 2 years, a 12-year-old or an adult. They vary as people change. And so that's important in understanding the normal ranges and therefore interpreting whether the patient has a problem or not. We ask symptoms, and that's done on a drop-down list, and when we select the symptom, prompts will appear. Now here's an example of the prompt that appears every time you put in the symptom of cough. It reminds the triage nurse to check the duration of the symptoms, and if it's more than 2 weeks or there's any history of coughing up sputum stained with blood, then the patient should be immediately isolated from the queue and the senior nurse informed. Now that advice comes from the Ministry of Health Intensified TB Case Finding Form. And the Ministry produced this as good practice and expect that people will fill in this form every time they are meeting a patient with cough. But we would suggest that probably that's not very realistic in the clinics and hospitals around the country. People may not have the forms, they may forget about them, they may feel they're too busy to bother. But with Streamline, every time we put in cough, there is the prompt, and the important advice is there 24 hours a day every time that symptom is used. So it embeds patient safety in the program. So here's an example of a patient with cough, and now the data is being put in of the child's vital signs, and these are the Kisiizi early warning scores that help to gauge how seriously ill this patient is. Now then we introduced the incorporation of ETAT, which is the Emergency Triage Assessment and Treatment Tool produced by WHO. So it's actually built into Streamline. These are called emergency signs that are asked for each child under 12. And here are priority signs. And then the child will be triaged green if they're fine, red if they're very serious, or yellow if they're in between but need to be prioritized. And we are now achieving this screening of our children all the time. And then it shows up on the overview. The senior staff can see the flow chart. They can see any child or any adult coming through with a red or yellow triage and see what's happening. So we've managed to achieve 100% of the children attending outpatient clinics are having this ETAT assessment. And this is where IT can be very powerful because it can introduce something as a system and make it routine. And we've been delighted at how our staff have just adopted this as a routine. This is what we do, and it happens every day. And we know a number of children who previously would have waited in the queue and deteriorated have now been picked out and brought to the front and treated before they got worse. Now there are other tools, for example, the Safe Surgery Checklist, the Safe Childbirth Checklist, and we're looking at how we can incorporate them and involve them in Streamline for the same reason that it becomes a routine and doesn't get forgotten. Investigations, we haven't got time to go into detail, but one of the things that's important is we've introduced the authentication second check principle. So when a junior member of the laboratory staff puts in some results, before they are released to the clinicians and acted upon, they have to be authorized by a senior lab technician. And this dual check system is a great safety extra to ensure things don't slip through, which could cause dangerous problems for patients. Now, I want to talk particularly about medicines because this is such a key area at the moment. You will know that the WHO in May produced this publication on patient safety, making healthcare safer. And they remarked that the most common adverse safety incidents relate to surgery in 27%, but medication errors are 18.3%, and then healthcare associated infections 12%. So there's now a new, in fact it's the third global patient safety challenge. The first ones were to do with hygiene, hand hygiene, and keeping things clean, and the second one to do with surgery. And now the challenge is to do medication without harm. And the goal is to reduce the level of severe avoidable harm related to medications by 50% over 5 years globally. So the question is, how do you do that in the front line on the ground? And again, Streamline has something to offer. Here, for example, we record any known allergies of the patients, and Streamline will prevent you prescribing any drugs in those categories. Then, if we take the principle of good communication with patients when dispensing medicines, Streamline will generate labels with information in the patient's language in 100% of our dispensing. So previously, we just had these plastic sachets, which are widely used across Uganda, and we would just write on them with a ballpoint pen, and that was not very clear and not very easy to understand. Now Streamline will produce this very simple label. It's produced on a receipt printer, so it's very cheap, very fast, but it gives the key information about the patient and the medication. When we take registration details on Streamline, one of the questions we ask is about their language preference, whether it's for English or vernacular. And then it means that we produce the labels with the right language for that particular patient. Now here's an example of a tablet with 2 medicines in it. It's used in the treatment of TB. And the information tells the patient that their urine will become orange-red and that this is normal and they shouldn't worry about it but continue the treatment. Now we know that previously this information often was forgotten and wasn't told to the patients, and some of them, when their urine changed to red colour, thought something terrible was happening and stopped their treatment. And of course that is bad for them, but it also increases the risk of resistant organisms developing. Now with Streamline, 100% of patients getting this medicine get this information. And although it's true that some of our patients can't read, because it has their name on it, we find that a lot of them will go home and will ask their families or neighbours about what the label is telling them. So again, we have this figure of 100%. It's interesting that a system can allow you to achieve a really complete coverage of all patients getting that information. Behind this, there are a number of tables which are very easy to update and customize. So if we gave this program to a hospital in a different part of Uganda with a different local language, it would actually be very easy to update into the local language. Other things we do with it, I haven't got time to tell you very much, but we use it for stock control, and we can also influence prescribing. Here, for example, the pharmacist has written a note to prescribers telling them that they have a large supply of an alternative drug, and if clinically appropriate, would they please prescribe that to make it less likely the other drug expires on the shelf. Similarly, as soon as the clinician orders the drug, it's immediately on the pharmacy computer, and it can be prepared even before the patient gets to the window, so it can improve flow of patients. Now, one of the important things is the audit of errors, and here we see the view from the pharmacy as a prescription is received. They can see exactly who has prescribed it and the telephone number of the prescriber, so they can contact the prescriber very easily. And if they disagree with the prescription, they can contact the prescriber, agree a change, and then the pharmacist will make the alteration. But when they do it, they will then classify this error as wrong dosage, wrong frequency, inadequate funds or other, and they will grade it as mild, moderate or severe. So all we are asking the pharmacist to do is 2 clicks of a mouse to enter that data, but the result is that we get 100% prospective audit of any prescribing errors. So when we want to report that, we look on the system. You can generate a report that will show all of the errors in a particular time period, and that allows constructive feedback to the prescribers and appropriate training. So again, we've got 100% cover, where before we used to do paper audit and it was patchy and not always very effective. Another thing we've incorporated to show you an example is that it's good practice to report any suspected adverse drug reactions. That improves medication safety not only locally but around the world potentially. And we've provided a direct link to the National Drug Authority forms so that for the clinician it's very, very easy to give that report without having to go searching for where do I need to send this and where's the website, and you can go straight to it with one click on the page you're working from. And we believe that increases the efficiency of the system. Now, another thing we've done with Streamline is to make previous records available so that doctors and clinicians have access to stored x-rays, reports and so on. So here, for example, a patient has got 6 documents in store. When you click on this button, it will show you what is available. When you click on a particular one, it will open up something like a clinical photograph. In this case, the child has swelling over the left clavicle. You can then use that as a comparison when they come back to see you again in the future. Or you could store a chest x-ray such as this one. It's really helpful to have some of these available 24 hours a day, and often our patients forget them, or if they do bring them back, they're often creased and spoiled. We can also store things like histology, biopsy reports, clinical photos, etc. Then up-to-date resources. Sometimes people are struggling with paper if they're looking for protocols, they've been moved by somebody, they can't find them, but on Streamline, they're available 24 hours a day. Here, for example, is selecting the pediatric department, and here are a number of different resources available, and they're immediately available from any computer that accesses Streamline. And people can look up advice, and they can look up procedures or whatever is stored, and the departments can choose what they store in their folders. Another important aspect of patient safety is clear handover between shifts and communication of transition of care. And Streamline helps this with things like inpatient bed order and other lists. So here is an example from Children's Ward of children by bed number, showing their names. We've hidden their names, but their age, their triage and their working diagnosis. And there's also a column allowing actions needed that talks about things and can help to prioritize work. So what I'm trying to show you is how we've implemented some of these principles in practice. Data collection is now understood as being a very key thing in managing healthcare, but is often patchy and weak. And verification of data is often difficult, but Streamline is taking data input by clinicians in real time, and it allows verification by drilling down to the underlying raw data. So if we go to a Streamline report, we can look at the Ministry of Health HMIS data, the Health Management Information System data. It will give us the figures, and it will allow us to drill down and look at the underlying data if we want to. Here's an example where we filtered and we've asked about nephrotic syndrome, and it's pulled out the patients on the system with that condition. You can then go into the individual patient and see anything that's stored on their record. Here's a copy of their medical note and a copy of the clinical before and after photographs. So this is a very valuable tool and very helpful. But looking at the big picture, we also want to do routine health screening, and Streamline facilitates this by looking at lifestyle factors. So here, for example, we routinely look at height and weight and calculate BMI automatically. We look at alcohol and tobacco use, and we look at family planning and identify any family planning needs. And Kisiizi is working with an organisation called U-Shape to develop family planning services, and this is a useful tool. So this means that 100% of our patients undergo health screening, the only exception, of course, being very sick patients who go straight into the emergency area. I haven't got time to tell you a lot of other things on Streamline, but just to let you know, it does finances, and this is an example of an inpatient bill, and Streamline can help us to get accurate bills and to produce them more quickly, which reduces delay in discharge of patients, which is quite important. So, ladies and gentlemen, colleagues, I hope you've seen that we have implemented some of the things on the WHO Universal Health Coverage list. The ability to find help from a well-trained health worker. We have facilitated access to quality healthcare through our insurance scheme, Mother's Waiting Home, training programs and audit. The finance for quality healthcare, the insurance scheme and Good Samaritan Fund have helped. And a lot of the other things have been supported by Streamline. Streamline was evaluated by an independent researcher in May this year who comprehensively interviewed users of the system and came to these conclusions: that it was an acceptable and feasible tool, that it had led to substantive improvements in clinician responsiveness to patients, that it had improved productivity of the wider scale of health workers, and that the competence of clinicians had been boosted. So we were very happy with those responses, and particularly the fact that the users are happy to use the system. One of the challenges of IT is getting people to use it, and this has encouraged us. We were able to write a letter for the Lancet Journal last year on faith-based healthcare, and within that talked about the piloting of Streamline, among other things. Streamline's just won the Up Accelerate regional initiative of the United National Population Fund, which was sponsored by UK Aid, and it's being presented at the Ministry of Health, with whom we want to cooperate. And if anyone's interested, we have a website with more information. I'll give you that at the end of the talk. We also do regular audit, and Streamline is very useful for audits. And we do other sorts of training. This is an example of a drama showing patient safety training to the London School of Hygiene and Tropical Medicine visitors who came. To finish, I'm just going to tell you that we hope you'll come and visit Kisiizi. We have some lovely scenery. We have the tourism. We have a zip line. We have a website. And the proceeds of the whole thing go to help the Good Samaritan Fund, which helps us look after these most vulnerable patients, which, as you've seen, is one of the goals of WHO. So I've illustrated some of the implementation within the hospital, in our training of nurses in our School of Nursing, the importance of power and our electricity company, the WHO links, the insurance scheme, and I just mentioned the tourism. So I want to finish by thanking our staff who work extremely hard and go the extra mile, and to our supporters and partners who've helped us run all of these different activities. Here is the hospital website and the tourism website, and also the Streamline site. I've also put a link showing you how you can register with the WHO African Partnership for Patient Safety Program if you're not already involved, and you may wish to do that because there are a large number of resources available. Finally, for those of you in the UK, we have a Friends of Kisiizi Day on the 7th of October at Brookside Church in Reading, when our Senior Hospital Administrator will be present. Ladies and gentlemen, thank you for your attention, and I'll hand back to the host to take any questions. Thank you very much.
Hello.
Hello.
Yes, thank you, Dr. Ian Spillman, for the wonderful presentation. At this moment, those with questions can bring them through.
Thank you, Dr. Spillman. This is Bonaventure from Seed Global Health.
Hello.
Hello, Dr. Spillman. Thank you for the wonderful presentation.
Thank you, Bonaventure.
Yeah, I was particularly impressed by the community insurance program.
Yes.
I've heard lots of amazing things about your program, and I think by all standards, I would say it's a role model for community health insurance in Uganda. I'm just curious, how do you see this being influenced by the proposed National Health Insurance Scheme?
Okay, thank you for that question. I know the National Health Insurance Scheme has been under consideration for quite a long time, and I think they've been looking at a number of models, including the Rwanda National Health Insurance Program. I think what they've realized is that there are budgetary constraints, and they are looking at also the question of how can they deliver insurance for the whole population and not just for the more affluent middle class who have jobs. So one of the achievements of the Kisiizi scheme is it actually works for subsistence farmers because it's very low premium and it's affordable, and it works for spreading of risk. So I think now as I understand it, the national leaders who are looking at the whole question are coming back to grassroots programs like the Kisiizi one. I would emphasize the 3 points I made to you, that for the system to be replicable, you need to have 3 key principles in place. You must have the population trusting the provider. If there is an institution that they feel will not be available, the service will be available, then they will not sign up for an insurance scheme with that provider. So for example, if they think that in the middle of the night the services are not available for emergencies, they'll be less likely to sign up. Secondly, we think that the programs need to be not-for-profit, because if you have any profit incentive, then we think that people will be suspicious and not happy. Whereas our own scheme, people know that it's not for profit, and if we say that we have to make an increase in a co-payment, for example, then they will accept that. And finally, it needs the involvement of the community. The model we used was based on funeral groups called Ngozi groups. They were existing already, and we've added groups since then, but the structure was already there at the beginning, and that has worked really well.
Thank you so much. That really helped.
We will take another question. Thank you very much, Mr. Ian Spillman. I'll request, in case you are not speaking or using your microphone, you kindly mute it. We only leave the microphones for the members who are speaking to be unmuted. Any other question, please? You can come through.
Hello, Catherine Hanaway.
Hello.
Hello, Ian. We met when I was in Kampala earlier this year. I was talking about leadership.
Yes.
So thank you very much for your really impressive and useful presentation. And well done to you and your staff and your partners for the wonderful work that you are doing in Kisiizi. I'm currently working with Lord Nigel Crisp on the global nursing campaign called Nursing Now, implementing the recommendations of the triple impact report that came out and he launched earlier this year. You talked quite a bit, Ian, about nursing and nurses and the appointments that you had made and the usefulness of that. I would like to ask you what, as we try to help reach universal health coverage, can nurses do to really help to achieve that, and what more can we do as a global campaign in your experience?
Right, thank you. That's a big question because universal health coverage is very broad, isn't it? There are various aspects of it. For example, I think WHO includes things like palliative care. It talks about health promotion and prevention, as well as curative services and so on, and rehabilitation too. So I think nurses have crucial roles in many of those areas, if not all of them I think actually. And I think the points I would make, first of all, the specific role of a patient safety nurse, we found it's really helpful to have somebody who has that primary focus rather than tagging it on Previously, we had a part-time infection control nurse who was doing another job as well. We broadened the remit from not just infection control, but to patient safety, for example, including safe surgery, including medicine safety, and so on. Obviously, building training into student curricula is the start point, as nurses are trained in the first place. But I think one of the things I hope you're seeing from, for example, Streamline, is the reinforcement of good practice, so that if you're a triage nurse, for example, every time you run a triage, you are being reminded of key things, and it helps you to improve your skills and get the satisfaction that comes from recognizing the patients who need help and seeing them go through the system, rather than the appointment you have when somebody collapses in your queue because they weren't recognized. Obviously, community is key, and one of the areas we're very excited about is how can we use our 204 community groups in the insurance scheme, how can we mobilize that existing 38,400 beneficiaries into health promotion, into prevention. So, for example, we're looking at things like screening, mid-upper arm circumference screening for malnutrition in the children in those groups, looking at visual acuity screening for cataract. There's all sorts of things you can imagine, and as a screen to find and prevent problems getting worse, so that's part of HC. Then there's also interventions we're experimenting with. For example, we recognize that our top numerical diagnosis in children's ward is often respiratory infections and pneumonia. And this is usually in young children and infants. And we think that one of the factors may be to do with the fact that many of these children are on the mother's back, and the mother is spending quite a lot of time in the kitchen with a lot of smoke. So we've been experimenting with efficient stoves that produce considerably less smoke. They're also, by the way, economically an advantage because they use less fuel and they're better for the environment for the same reason. Now, we're trying to put those into some of our community health insurance groups in the hope that we'll have a double win, because it will help those particular families, but also if their children do not become ill, then they will not use the services, and that will save cost on the insurance scheme. So it's a good way to start. But nurses have opportunities in health education and promotion on that sort of area. I talked about the Ruchiga videos. Again, we've used nurses to make some of those, both by giving commentary, but also by role play. So for example, we had one of our nurses played the part of a mother of a sick child to get across key points about gastritis management and so on. So I think the sky's the limit in terms of how nurses can be involved. In terms of the global picture, I think that the work we did in Geneva at the end of 2013, published in 2014, raised a number of important principles, as I showed you, but was a bit weak on how do you implement, and that's what we've been trying to think about. And as I've shown you, I think some of the principles can be achieved with the IT. And I think looking further ahead future-wise, there's no doubt that IT is becoming more and more available and more important, and people are increasingly recognizing the vital importance of good data. Now, before we did Streamline, we had a system where our data was often being collected by non-clinical staff who often had limited training and were trying to decipher retrospectively what had happened from the clinical notes. And that was sometimes difficult for legibility or because of abbreviations and so on. And by changing it to a clinician-entered data, you get better quality data, and that can guide you in real epidemiology and real planning for your health systems. So I think there's a lot of dimensions to universal health coverage, and I think, yeah, nurses have a crucial role to play, and I think some of the things we've shown are steps. We've still got a long way to go. There's still lots of things we don't do very well, but I wanted to share what we felt had helped us in the hope that it will help and some of the other units. Thank you.
Thank you. Thanks.
Right, any other questions?
Hi, it's Anna Lee from the Global Health Exchange.
Hello.
I'm just wondering, it sounds like you've made some really great achievements over the last couple of years, and I'm just wondering how is this formally being spread to other facilities in Uganda, but also regionally?
Okay.
Learning from this?
Thank you, Anna. As you've seen, we've covered quite a lot of different areas. So the answer depends on the different areas. Now, somebody's already asked me about the insurance scheme. We think that's quite strategic. We think that's helped a huge number of people. And we also think it's got great potential to further develop in terms of health promotion, as I just explained. So that has been shared. Lots and lots of people, both within Uganda and internationally, have come to look at the scheme and gone away excited. And some people have been starting up schemes. So yes, that has been shared a little bit. In terms of some of the WHO-linked work, the Africa Partnership for Patient Safety, the Surgical Unit-Based Safety Program, and the Learning Laboratory, we're actively involved in something called the Global Learning Laboratory, I think it's called, for universal healthcare and patient safety. That is, again, using webinars to link people up internationally. So we've been involved in that group. That's recently really been established and is still developing. But we were involved in evaluation towards how that could be done. We presented in other fora, in the Uganda Health Summit in London. We presented last year some of our work. So we're trying to use opportunities. We've presented at Uganda Medical Association. We're planning to expand Streamline through other sister hospitals, and as we have the full functionality, then it will become available more widely. And as I said, we're discussing with Ministry of Health about the program. I think Streamline incorporates a lot of safety issues. I only scratched the surface with what I told you. There's a lot of other things built into it. All of our insurance patients, for example, are on Streamline, which makes that system more efficient. It's an integrated system, so it joins up a whole number of areas. It, I think, has huge attraction for the ministry because it allows verification of data, which I think is difficult on paper. People can potentially make up figures, whereas Streamline, you can drill down and see the actual data below it and check the, you can verify that the patients are real and so on. There's all sorts of other dimensions that we're looking at to expand it. For example, monitoring CPD in individuals and monitoring what they're doing. You can, for example, track how many operations different people have done. You can track, we're going to be tracking CPD attendance, and that will then be a tool that may help the Uganda Medical and Dental Practitioner Council in their annual licensing. At the moment they have a paper that just asks you to record on paper your CPD, but again, it's difficult for them to verify it, and this is another tool. So there's lots of dimensions to this, and in terms of sharing it, we're open to different fora. This whole webinar today is an attempt to share some of this with a wider audience.
Great, thank you.
Do we have any other questions for Dr. Ian as we plan to... Any other question? Okay, so should we presume that we are all satisfied?
Okay, thank you.
Okay, so I take this opportunity to thank Dr. Ian Spillman. It's exactly, and we always plan our webinars not to go beyond an hour. Thank you very much, Dr. Ian Spillman, for the wonderful presentation. And as you mentioned, one of the core purposes of having such presentations staged on the UCA platform, the UCA Talk, is to also contribute to the strategy of spreading out, sharing learning, sharing good practice that members of the Alliance may be doing in their respective localities and sharing those with other members so that we can have a wide within the health sector. So it strongly contributes to our learning and co-development. All, thank you very much, and thank you very much for everyone who has taken off time to be present with us today. And we look forward to having you all in our next UCA talk, which will be at the end of September, the dates that we shall communicate so that we can further our core agenda of scaling up standards of good practice within Uganda, and also to share with our colleagues back in the UK, and also to have such skills spread amongst the members of the Alliance as we strive to achieve our ultimate goal of universal health coverage. Thank you, everyone. I'll beg to adjourn our call at this juncture. Thank you, everyone. Have a good bye.
Thank you.
Thank you. Thank you very much. Thank you. Bye-bye.
Thank you.
Bye.
Bye.
Everyone. Thanks for coming.